HS 1.5, as I mentioned, you can use esophageal endoscopy to show you the progression of the reflux to cancer, but the surveillance endoscopy is actually controversial. So let's have a look at why that is. Well, surveillance endoscopy, it's expensive and very labour intensive, and only 0.5% of people with Barrett's metaplasia progress to adenocarcinoma. And for these two reasons, using surveillance endoscopy has no effect on adenocarcinoma survival, and therefore it's controversial. So now let's have a look at the cancers themselves. Well, you can have squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is due to environmental stress, basically, and adenocarcinoma adenocarcinoma, as I mentioned, it's due to reflux, and incidence is shooting up, and there's poor treatment in Western countries, so it's a big problem, basically, and it's due to reflux. The environmental stress causes of squamous cell carcinoma are things like tobacco, alcohol, and strictures and things. So we can compare these two, squamous cell carcinoma versus adenocarcinoma. You can look at the site. Well, squamous cell carcinoma is mid and upper esophagus, whereas adenocarcinoma, it's more likely to be lower because it's due to reflux. You can have a look at whether there's a pre-malignant lesion. In adenocarcinoma, it's more likely that there is a pre-malignant lesion. In squamous cell carcinoma, it's not. And the cause is obviously environmental stress versus reflux. You can look at the gender that it affects. Squamous cell carcinoma affects male and female equally, whereas adenocarcinoma affects males more. 5-year survival, it's 10% for squamous cell carcinoma versus 5% for adenocarcinoma, so adenocarcinoma is less serious in that sense. And curability, they're both potentially curable at 25%. Incidence, as I mentioned, it's shooting up for adenocarcinoma, and it's higher incidence compared to squamous cell carcinoma. If you have these carcinomas, then two things really important to note. You'll have an irregular stricture. It's irregular, and you won't be able to swallow solids. You will be able to swallow liquids. As you can see here, you've got an increasing incidence of esophageal adenocarcinoma. You also have the conversion of the reflux, gastroesophageal reflux disease to Barrett's metaplasia causing adenocarcinoma. It has certain genetic defects involved. The Barrett's metaplasia results in genetic defects causing dysplasia, resulting in adenocarcinoma, and as I mentioned previously, it has a 0.5% conversion rate, which is why surveillance endoscopy is controversial. In terms of other esophageal conditions, there's achalasia, pharyngeal pouch, esophageal rupture, esophageal varices. So looking at achalasia first. Well, what is achalasia? Well, achalasia means failure to relax, and it has a viral cause. If you have a viral achalasia, you lose the myenteric plexus. Myenteric means to do with muscle. So when you lose the myenteric plexus at the lower esophageal sphincter, you'll get a motor disorder of the esophagus with increased tone. It's a loss of inhibitory motor neurons. So if you lose the inhibitory motor neurons, it's going to be greater contraction, lose the relaxation, poorly relaxing. This is achalasia. And it will result in various symptoms. For example, dysphagia, which is difficulty swallowing. What's different about this compared to the carcinomas is you won't be able to swallow solids as well as liquids. You'll have regurgitation, chest discomfort, and halitosis, which is bad breath. Also, because of the failure to relax, it'll tighten around here, around the lower esophageal sphincter, and so you'll get a smooth bird beak stricture. So bird beak implies that it's getting thinner. At this point, stricture means thinning. And because it's a failure to relax, it's contracting too much. One of the treatments is Botox. You can treat it if you treat it with you can paralyze the muscles with Botox. It'll cause it to relax. In terms of treatment, as I mentioned, you can use a Botox injection at the lower esophageal sphincter. This will cause the muscles to relax. Or you can use Heller's myotomy. Omi means removal, so Heller's myotomy, myo means muscle. Heller's myotomy, muscle removal. You take the longitudinal muscle fibers, you remove some of them, and these two things, Botox and Heller's myotomy, will treat the achalasia, will allow it to relax. So that's achalasia. The next thing to look at is pharyngeal pouch, as I mentioned in HS 1.1, I think it was. The esophagus looking posteriorly. Let's just take the esophagus. Esophagus anatomy, looking at it posteriorly, it's got muscles, it's also got these bare areas. The bare areas, posterior area of cilium, it's therefore susceptible to pharyngeal pouch. Looking at pharyngeal pouch, it affects men more than women. It also affects trumpet players, and it can be due to traction diverticulum, so food pushing on it, essentially, causing a diverticulum sticking out, right? This will result in a defect at cilium's area, which is between the cricopharyngeus muscle there and the inferior constrictor there, which is near at the top, and this will cause pharyngeal pouch, which is posterior pharyngeal pouch in the cilium's area. This will cause difficulty swallowing, dysphagia, regurgitation, and a bad breath, which is halitosis. And this traction diverticulum, you can use surgery to cut and staple the pharyngeal pouch. So the next thing to look at is esophageal ruptures. What can cause esophageal ruptures? Forceful vomit, or Boerhaave syndrome, not sure what that is, or physical trauma will cause esophageal rupture / perforation. It can either be less severe, which is a Mallory Weiss tear, or it can be more severe. If it's less severe, it's going to cause superficial tear and bleeding. If it's more severe, it's going to result in severe chest pain, emphysema, and pleural effusion, which is more likely on the left side, which is free air, and sepsis, which is infection due to the food and bacteria that you're eating is going to pass into the mediastinum, causing mediastinomitis, I think. And this rupture, you can use surgery to repair it. So what have we looked at so far? We looked at achalasia, gastroesophageal reflux disease, achalasia, pharyngeal pouch, and esophageal rupture. But finally, we have esophageal varices. A varices is it's due to increased pressure. It sort of sticks out on the surface. So if you look at varices in the leg, you'll be very, very veiny legs. So what can cause this esophageal varices? Well, as I said, it's to do with increased pressure. So let's see how that can happen. Well, if you have alcoholic liver disease or viral hepatitis, you're going to get liver cirrhosis. Well, fibrosis first, then liver cirrhosis, which is like a rough, bumpy liver, which is the hepatic cause. And this will cause resistance to portal blood flow. Remember, the portal vein passes through the liver, causing increased portal pressure, resulting in varices, which is dilated vessels. If you get these varices and they rupture, then it will cause an anastomosis, which is an abnormal connection between the portal system and the azygous system, which is not portal, of the lower esophagus. And therefore the blood, you'll get it's called a collateral circulation. The blood will bypass the esophagus. It will bypass the liver, so you get increased toxins, causing encephalopathy, which is confusion. How are you going to treat all this? Well, if you use beta blockers, that will reduce the vascular tone. Beta blockers low blood pressure. So you're going to get reduced resistance to blood flow and reduced portal pressure. if you use a Sengstaken tube or an elastic band on the varices, then you can reduce the pressure on the varices and the dilated vessels. A Sengstaken tube is like a connection that somehow reduces the pressure, but I'm not sure. Right. Also, you can use you can use a transjugular intrahepatic portosystemic shunt. So a shunt is a connection, portosystemic is a portal to systemic, and the shunt will cause the portal vein blood to go into the vena cava rather than going into the systemic system. So that will prevent the anastomosis. That will fix the anastomosis. However, the definitive treatment for these varices, increased liver pressure, the definitive treatment is a liver transplant.